Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Here, we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. And today we're going to be talking about risks of vaginal birth. And I have a very special guest, actually my Twitter mutual, Dr. Jocelyn Fitzgerald.
Hi.
Hello. Dr. Fitzgerald is an assistant professor of OBGYN in the Division of Urogynecology and Reconstructive Pelvic Surgery at the University of Pittsburgh School of Medicine. Hello.
Hello.
Welcome.
Thank you for having me. It's so much fun when, whatever X, I guess it is now, or Twitter turns into real life. It's so many more words that we can say.
I know. I love following your tweets. They're just, I learned so much myself. I think the other day you tweeted about how so many women don't even know about that there's this whole field of medicine for women, urogyn and pelvic reconstructive surgery. And so I thought we'd start by you telling us about your journey, like a little bit about how you got to this specialty, and then even just explaining what it is.
Yeah, absolutely. I think urogynecology is the best. It incorporates so many things. It's perfect for me, I guess, but it incorporates so many interesting social dynamics. And I kind of started getting really interested in it. So funny, I just gave a presentation on this a little bit earlier today where my mom was present. And she's important to the story because I am the oldest of 8 children. I have if any of you know anything about eldest daughter syndrome, which is all over social media, yes, it's exactly women in healthcare. And I'm the oldest daughter of 2 oldest. My dad and my mom both oldest in their family, oldest of 8 kids, prototypic eldest daughter syndrome in every way, shape, and form. So of course I was going to go into healthcare, but I remember going to Magee Women's Hospital where I currently work. I went there 7 times as a kid to pick up my siblings. I don't really have memories prior to my 4th brother being born, but I remember feeling like it was a really important place where women were taken really good care of. And my mom, she had all these babies and she's one of 7 girls. I have 6 aunts on her side, and they would always just be talking about, all sorts of health things. And I remember, I don't think I could put it into words of being struck at a young age by this total lack of information and a lot of stuff that women kind of talk about only in hushed voices. They don't really share necessarily with the world or with their partner. And, a lot of things that happen to them or new symptoms that they had after having, several children. And I was like, well, who takes care of this? You always hear about orthopedic surgeons taking care of athletes' knees and sports and all this stuff, but who's taking care of the women who are having babies? That's a sport. That's serious business. And so it's kind of time marched on. I got really interested in other issues in women's healthcare, like reproductive justice and just things that even as a teenager, I realized set me apart from my male counterparts, and that there was a lot of influence that a doctor that had a voice in that space or had information to share could really make a difference in how women move through the world. So in college, I double majored in women's studies. Penn State is where I went. They actually had a Bachelor of Science in Women's Studies, which was really cool. It was a big enough school that I could make a lot of my science classes count. So there were a lot of behavioral health classes that, had some feminist theory behind them, but also a lot of biologic basis. So I took classes on menopause. I took classes on reproductive justice. And then it all kind of double counted towards my other major, which was biology. And I was like, I'm going to be an OBGYN of some sort. And I definitely want to be a surgeon of some kind. So how can I combine those 2 things? And then in there were like a series of other like events, not to make this story too long, but some internships that I did that were very much surrounded like around menopause and like the way that we legislate menopause and the way that we fund menopause. And I was in DC for a lot of that. And I was like, okay, but what surgical problems do women in menopause have? And it was like incontinence, prolapse, like recurring UTIs. It was kind of this like female urology hybrid. And I thought that is cool. That's a way to really lift up women who are post childbearing and have a lot of like political, economic, social influence at that time. That could make a really big impact. In medical school, I was really lucky. I came back to Pitt, where I currently work. My mentor here, and she's the head of our division, Pam Wally. She was my mentor in medical school. She's a world famous urogynecologist. She's just an incredible individual. And then it kind of went from there. Like I went to residency at Hopkins knowing that I wanted to do urogyn. And then I did my urogyn fellowship before coming home. And all of it has turned out to be true. I must have had some really good voices in my ear. And that's kind of my path. And that's why I think urogyn is so important. I continue to think it's important for all those reasons. And it is all very rooted in really what I was taught about like feminist economics and like the economics of women's bodies and how we legislate them and how we pay for them. And anyway, here we are.
Thank you. Thank you for sharing that. I really think it's so wonderful. You were inspired by your mother's experience and your family. And I love that you did women's studies in college. People minimize liberal arts educations, and they really shouldn't.
They shouldn't.
Like you said, it makes you a better doctor to have to not just be to be focused on social issues. So, and I also love that did I get that right? You work in the same community where you grew up? Is that right?
I do, yes.
Oh, so cool.
It's a really powerful thing. I think anyone who practices medicine in the community that raised them knows that that's a really unique therapeutic relationship. I just came right before this podcast giving a talk to 600 women from Pittsburgh. I had no idea that it was going to be this many people. And my mom and my grandma came with me, and I didn't even tell them about it. I thought it was just, I'm doing this for work. Like I was invited to come talk at this patient outreach, like Ladies Day Out event. And my grandmother heard women talking about it at her community center. She's like, that's my granddaughter. And called my mom and was like, Jocelyn's giving a talk about incontinence and urogynecology. What is this about? And so anyway, then they wanted to come. So it's precisely like that. I mean, these women were asking me so many questions, and the way I answered them, I was like, I always practice medicine as though my mother and grandmother were sitting in front of me. And today they really are. So the answers I'm giving you are the answers I tell them at the dinner table when they ask.
That's so really special. That's
how I practice medicine. It's also a lot easier to understand like the values of a community that you're from, which is why representation in medicine is so important. Like it's this unspoken thing. Like when you understand what shared experiences you have with your patient, they are so much more likely to both trust you and know that you're thinking about their treatment plan in the context of what's important to them.
That's such a good point. Well, I wanted to talk about this topic because I saw you tweet about how OBGYNs should, and other providers who take care of women in labor should really be, and pregnancy, should be counseling patients about the risks of vaginal birth and consenting like we do for C-section. And that really got me thinking. I mean, that's what led to this particular episode, because I was like, you know what? We don't talk about it enough. And especially now in this country, in this environment, which just feels like, with the political changes happening, like Roe and these birth control restrictions and these very strong conservative online influence kind of pushing women to pregnancy. And sometimes I see comments, often from men, making it seem like pregnancy is just natural and normal. And this is what women were just meant to do. And this is your purpose in life. So I feel like there's an agenda to get women barefoot and pregnant, and a lot.
I agree. Yes, as you know from following me on Twitter and anyone who's listening, I feel very strongly about this. First of all, the idea that like women are vessels for childbearing and we're just like born to do this has been honestly debunked many, many times. Like the human female pelvis actually has not really evolved at this point to be super good at childbearing. I mean, that is why C-sections are very necessary. Like in a lot of circumstances, I've practiced medicine with some people who are evidence-based in doing everything that they can to prevent the first cesarean delivery, which is a good thing to do. Cesarean deliveries are major abdominal surgery. I hope no one listening takes away from this that I think that cesarean birth is like better than vaginal birth. That is not the conversation that we need to be having. What we do need to acknowledge is that even someone who is trying to avoid a cesarean birth at all costs is still going to have to do a certain number of C-sections to keep women safe. And that's not for over medicalization of birth, in my opinion. Like, obviously, there's bad apples everywhere, but in the times that I've practiced obstetrics, it was with very, very conscientious people practicing, like I said, evidence-based medicine, doing patient-centered care. And there is a reason that women and their babies don't die in childbirth like they used to hundreds of years ago. It's because we have surgical and other technology that can intervene. So that's the first thing I kind of want to say. And then the second thing is that, yes, I very much think we are devastatingly entering this discussion about, again, as you said, like birth being like natural and easy, when in fact, many women across this country already are being forced to give birth. And that is so far from benign. Not only is like pregnancy not benign, but birth is not benign. Those are like two things happening at once. As a urogynecologist, obviously I deal more with the aftermath of the birth than the full body consequences of pregnancy, which anyone in any specialty will tell you affect your brain, affects your heart, affects your lungs, affects your gut, affects your bones, muscles, ligaments. I mean, it's crazy the long-term effect that pregnancy has in your body. But in terms of your pelvic floor, I mean, 50% of women will have a pelvic floor disorder in their lifetime. That includes incontinence, prolapse, fecal incontinence, pain with sex, like birth trauma, tears, levator avulsions. I mean, these are really significant things that we don't talk to women about before they get pregnant. And I like to say, and I truly do believe that if you go up to a woman who has never had kids before and I tell them, like, I'm a urogynecologist, they ask me what that is. And in order to explain what I do, I have to explain what diseases support my existence. And I explain to them, like, having babies really precipitates and sometimes causes some pretty terrible trauma, and your vagina can fall out. You'll start leaking urine. And just by existing, by explaining to them what my job is, it reveals to people a whole lot of problems that they had no idea existed or could happen from having a baby. And they're like, I wish someone would have told me this. And no one really does. So that's why I say, like, just literally informing someone that urogynecology exists means that you have to admit there's a reason urogynecologists have to exist, which is part of the, I think, consent and counseling process.
That is such a brilliant point. And we do need to educate women more. And I love that point of how we have not actually evolved to the point to make childbirth easier. You know, like you'll see mammals in the wild, just they drop their child, and a few moments later the baby is walking, the infant mammal is walking. But for women, labor is hours and hours and hours of duration, and we've evolved to assist each other. So childbirth is actually very difficult. And because of that baby head size being so large compared to the pelvis. And so that being that way just predisposes us to more complications and risks.
Exactly. Our brains are big enough to figure out how to do a C-section. Ironically, because we needed to be smart enough to figure that out, because our brains are too big to like fit out of a pelvis all the time. And there's also a lot of genetic diversity in the human race in terms of like I mean, you'll have like sometimes I'll have patients, they'll be like really, really petite women, and like their partner will be like really a different size than them, like very different habitus. They'll be very big and they'll have these huge babies. And you're like, well, that's not going to fit.
Exactly. There's all different shaped pelvises, size pelvises. Yeah. And that actually just makes me think of like why we should be as much as possible trying to prevent teen births, because young women's pelvises are not fully developed, until I believe in the 20s, right? Not as a teenager.
Right. No, it is so true. I used to know this data, and you might know it. Like the rate of C-section, I think, is significantly higher before like the age of 18 or 17. Like I remember the really young teenagers whose babies I unfortunately delivered in residency. Like they were almost all C-sections because they were so narrow.
Right. And so again, like this notion by some people that just because you're having a period, that's nature telling you you're ready to have children. No, absolutely not. For many reasons, including developmental reasons and maturity and education, but also and situation in life, but also your pelvis is not ready for it.
Right. So people, I thought something the other day. It's like, would you let a 10 or 11-year-old babysit for your kids? Like, if you wouldn't, then you should in no way, shape, or form think they should be having children.
Mm-hmm. Exactly. Okay, let's get into it. Let me have you maybe start with telling, I think people probably don't have a concept of what the pelvic floor is, how to think about it.
I'll describe what I'm doing. I have a
pelvic
model.
Thank you.
That I often describe in podcasts like this. I do a fair number of them. Anyway, this is a female pelvis. This is like head on, obviously without the soft tissue on top. And the important thing to gather from this is that the pelvic floor is this like bowl of muscle that has several attachment points to the bones in the pelvis. And in the process of doing so, its job is to support the three outlets of the pelvis. So the urethra, which is the opening of the bladder, the vaginal opening, and the anus, which is the rectal opening. I actually have, there's the uterus and vagina, the rectum, and the bladder. These are the organs that sit inside of the pelvis. And actually, for those who can see this, again, if you can't describe it, but this really is like a bowl. It's shaped like a bowl. And it's a really complicated system of muscles, bones, ligaments, tendons, and nerves that come out of the spinal cord back here and do some really sophisticated control of these hollow organs that constantly throughout the day are filling, emptying, sending sensations, to your pelvis through your brain, telling, you have some voluntary control over it, some you do not. You have to find a socially appropriate time to use the restroom. And that isn't to even, start about like the vagina, uterus, fallopian tubes, and ovaries, which are in charge of all of your reproductive and also like sexual functions. So there's like the clitoris that's here. I mean, there's a lot of like pleasure sensations and sort of that kind of like neurologic drive, but also all of the reproductive, the menstrual cycle, the endocrine function of the ovaries, the support function of the vagina, and also the fact that the uterus can expand like 400 times and hold a full-term baby inside of it in this bowl. I mean, this is a really dynamic set of structures. I don't think there's another part of the body that's quite like it that I can think of. Something that just does so many sophisticated things and changes size, shape throughout a woman's lifetime so dramatically.
A lot of functions, very underappreciated. People don't know about it.
We all take for granted, like being able to hold our pee and poop. I mean, but that takes a wildly sophisticated like setup of nerves, muscles, etc. And we all just like expect it to work. But as soon as it doesn't work, it is like a catastrophe for obvious reasons.
So tell us the major things, major problems, pelvic floor disorders that you get referred to by doctors like me.
Yeah. And thank you so much for your referrals, of course. So if we're looking at the bowl of the pelvic floor again, truly think about like a gravid uterus that is so huge that like socks down into here. And, this is a pretty anatomically accurate pelvis, maybe a little smaller than real life. But, for this to all come apart and for the hips to expand to the point that like a fetal head can come through this, you can see a lot of opportunities for where these muscles could certainly tear. Mm-hmm. And a lot of the support structures around the bladder could definitely be stretched, avulsed. They could get crush injuries. You can get nerve injuries. You can have just like a lot of opportunities for pain and disruption in all of these structures. And so as a result of that, the most common things that I see patients for are probably urinary incontinence, because that sort of really starts pretty immediately postpartum. A lot of people think urogynecology is a field where we take care of only old women, and that could not be farther from the truth. And I truly think that social determinants are what have historically made that happen. Yeah, like young women, maybe their incontinence isn't as bad, but I do think we've normalized postpartum incontinence so much that by the time it gets so bad that women can't do their daily activities, or they're embarrassed, or like their life is totally taken over and they've gotten motivated enough to find me, now then they're in their 50s, 60s, and 70s. And there's like maybe several things that have happened that have made their incontinence worse. But my friends who are all in their mid to late 30s at this point, and many of whom are done having their kids, are texting, calling me constantly that they're leaking at the gym. They can't run like they used to. They are afraid they're going to leak with sex. They have some bowel incontinence or some gas incontinence. Like they just have kind of like lost control of their pelvic floor, and it's really starting to affect them. So incontinence is the bread and butter of, I think, what people see me for the most. And when I say incontinence, there's two main flavors, though there's a few other, root causes. There's stress incontinence and urge incontinence, both of which are made more common by childbirth. So stress incontinence is sort of classic, like I sneezed and I have to cross my legs after I have a baby because a little bit of pee comes out. I can't jump on a trampoline with my kids. I really want to, but I can't. That's stress incontinence. And then urge incontinence is when you can't get to the toilet in time. You've kind of lost control of your bladder function in that you're having a bunch of bladder spasms that are triggered in opportune times, and the urine just kind of comes out because your pelvic floor isn't strong enough to stop it. And that can happen from childbearing because of the really complex nerve plexes that are running through the pelvis. And those can be, like I said, crushed or stretched during childbirth and take a while to reheal or to kind of get that function back. And they can have a big effect. So urinary incontinence is the most common. But I see people also for fecal incontinence pretty often, and prolapse. Prolapse happens at younger ages than people realize.
Do you want to could you explain prolapse to everyone?
Yeah, absolutely. And I always am looking, I think people they dance around prolapse. They're trying to find like a graceful way of explaining what it is. But like ultimately I tell people, I'm like, it's when your vagina falls out, and it doesn't always fall all the way out. There's a spectrum. Sometimes it only falls out a little bit. Sometimes it falls out all the way. Most people are somewhere in the middle, but the vagina, which I'll hold up my little model, but also again explain, has an upper portion and a lower portion. The upper portion of the vagina holds the bladder up like this. The vagina is really like a clothesline. It's like responsible for holding the bladder straight so that urine can flow downhill. Same thing with the rectum. So the back wall of the vagina is responsible for like holding the rectum in a straight line, more or less, so that, the pelvic floor can do its job when you're sitting on the toilet to empty the contents of your bowels. So those are sort of the upper and lower functions of the vaginal support. And then up at the tippy top of the vagina, sort of like if the vagina was a tent, the bladder's the front wall, the rectum's the back wall, but the like pinnacle of the tent holds up the uterus. And so there's some ligaments back here that also get stretched out during childbirth. And if one or multiple, either the front, the back, or the top of the vagina gets damaged, then it can sag inward and like gravity like pulls these organs out with it. So you can get bladder prolapse. That's when the front wall of the vagina has damage and sags inward. You can have a rectocele, which is when the back wall of the vagina has a tear. Those are really common. Like if you have an episiotomy or a tear from childbirth and it weakens the back wall, that's when like the rectum will sort of bulge into the back wall. And then some patients, their uterus like plops forward and kind of telescopes the vagina. So prolapse is when the vagina loses its structural integrity and the organ behind it droops down into the vaginal canal.
So you have a problem, with your pelvic floor potentially when you have incontinence of the urine or feces, but also like what are the symptoms with the, I think it would be good to maybe talk about some of the symptoms to alert people for pelvic organ prolapse, like besides feeling a bulge,
Yeah, definitely. A bulge is the most common one, but some people say that they feel like something is blocking their ability to either empty their bladder or their bowels. They might feel, if they're having a rectocele, they might feel like they have to strain a lot to have a bowel movement, like it won't come sort of straight out or that the stool is getting stuck. That's a pretty common symptom. On the bladder side, sometimes women can't really feel that their bladder's fallen, but it is sort of, the bladder kind of sits straight like this. It's like a balloon on its side, but when the vagina bends down and the bladder falls, it kind of kinks off the urethra like a garden hose. And so some women start getting recurrent urinary tract infections because they're not emptying their bladder very well, or they feel like they have a lot of hesitancy when they sit on the toilet. Like they feel like they have to go and they're trying to start the stream of urine and they can't get it to start. And sometimes they have to like push the bulge in or kind of do something called splinting, which is when you put your finger in the vagina and sort of support your organs so that everything comes out smoothly.
Right.
Those are the big ones. Sometimes pressure.
So another thing I wanted to talk about, well, besides childbirth, so certainly childbirth contributes to all of these problems, but there are other risk factors, right? So, I mean, I tell patients that gravity itself is just a risk factor, and that all women should expect, like, some, not to be necessarily alarmed with having a bit of prolapse, because I kind of say most women have some. It's whether you're symptomatic or not. Like, when do you seek a doctor? And well, first the other risk factors.
Yeah, no, I think that's so important because I always, whenever I post about this, and absolutely, like childbirth is the biggest risk factor, but it's not the only one. And I have many patients say, like, comment, you don't have to have a baby to need a urogynecologist. And that could not be more true. If you have chronic constipation, if you have a chronic cough, if you have a connective tissue disorder like Ehlers-Danlos syndrome, other collagen disorders like other hypermobility syndromes, those are big reasons to have prolapse. And so you don't have to have had a baby. So if you're like, I have these symptoms, but I can't possibly be what's going on. I've like never had kids. That is not true. Like, absolutely, you could have those.
Right. Yes. And also like weight, like, because basically your pelvis is just kind of supporting a lot of weight, in pregnancy, it's baby, but also your own weight can apply a lot of strain. And in menopause, I always tell patients, well,
menopause, aging. I like what you said about gravity. Like, I mean, it's kind of a joke, but like,
yes, I know.
One's
everything
like
sags.
Everything sags. It's like your breast or your face, like everything loses its collagen integrity over time, and your vagina is no different.
Yes. So I'll sometimes tell patients, okay, you have a mild cystocele, that's the bladder drop, and that sometimes it upsets people. And I said, oh no, that's pretty normal. You can have common. That. The problem, the question is, are you having any problems, or if they're having any symptoms, or so when is it a time to address this with the doctor?
Yeah, I always say when it bothers you, and that can mean different things to different people, because sometimes people are just bothered by knowing that it's there, even though they can't feel it, and it's actually like physically not bothering them. And this really does, like, I've had so many like general gynecologists say to me, like, I'm so torn over if I should tell people when I see an asymptomatic, like cystocele or rectocele, like, should I tell them? Or should I not tell them? Because, if they're asymptomatic, like it's true, there's like nothing really to do. And I think about this too, because I have a lot of patients that come see me and they're like, my doctor told me that I have a cystocele. I'm like, okay, can you feel it? Does it bother you? They're like, no. I'm like, okay, so like there's nothing to do. But I actually am team telling people. I do think it's a good thing to do only because, and like there's definitely a way to do it, to be like, you have an early stage of this, and I'm telling you because I want you to know that if it gets worse, which they don't all do, prolapse, honestly, 1/3 of them stay the same, 1/3 of them get worse, and 1/3 of them can even get better. I just want you to know that there is a specialist that if this were to get worse or it were to start bothering you, now they can fix it. If it becomes symptomatic and bothersome, and most people have symptoms and are bothered when some part of the bulge like kind of comes into contact with the hymenal ring. So when it gets to the opening of the vagina, people tend to be more bothered. But yeah, I've gone back and forth about this a lot. And it's like the easiest consult in the world for me to see a patient.
Right.
And just teach them about prolapse and what it is and reassure them that their prolapse is mild and that if anything changes, come back and see me and you're an established patient. I'll be here for you.
Yeah, I'm also on team telling people because
it's not really up to us,
Yeah, I mean, if it's significant enough that I would want to write it in a note, then I should tell patients because it's the age of medical records. They can read their notes. So that's silly not to share that, especially if it's something that you think may turn into something worse, like you said. And I mean, we're having this podcast for a reason, right? To educate. So it's an opportunity for you to do some teaching to an individual patient about their pelvic floor, which they don't know about.
Totally agree. I don't think that people should like selectively keep anything from women thinking they can't handle the information. I guess you get upset and that's okay. It's like, all right, if people get upset when you tell them they have something they didn't know that they had, but obviously like an emotionally intelligent doctor should be able to say, this is what I see in your exam. This is what this is, just as you've described.
We need to fight the patriarchy in the world, but also in medicine and not be paternalistic and just, tell patients to not worry their little heads. We should tell them because they're intelligent women.
Correct. Consenting people for operative delivery and consenting people for childbirth. Like it's not our job to be paternalistic and be like, oh, I don't want to make them anxious or I don't want to worry them. They're going to have the baby anyway. Like what's even the point of telling them about prolapse or what's even the point of telling them the risks of forceps? Like those are real things. Like you do have to it's not up to you to decide like what women can and can't handle of the truth.
And this is a topic I think we need patients to, women should know about this before even getting pregnant and having children.
Absolutely. They deserve to know. It's just another piece to the puzzle. People who really want kids and have really thought long and hard about the pros and cons of becoming a parent, this is not going to stop them from becoming a parent. What it is going to do is give them a resource. So if and when they experience these things, they know where to go. And there's actually research that shows that's the case. It doesn't actually increase anxiety to counsel patients about these things. It actually decreases their anxiety because now they know if it happens, it's common and there's help. So that is definitely a real myth that's been
I mean, there may be women avoiding pregnancy entirely because they think this can maybe because of a family member's experience or what they've heard. They might be avoiding it because they think that nothing could be done if something like this happens, Yeah.
So that's actually a great point and a great counterpoint to anyone who says like, I've gotten some criticism for talking about this online. People saying like that it's fear mongering or it's antinatalist. Like you're saying that women shouldn't have babies if they don't want their pelvic floor to get messed up. But like the flip side of that is actually I'm trying to teach women that there probably is a subset of women who maybe want kids but are too scared to have them. And
absolutely. It's part of family planning. Plus, I think it is. I mean, this is something I want to discuss later. We'll go back to this, but basically, I mean, you may decide on a different number of children. Like if patients, for example, if patients are having, end up having C-section at their first delivery, we do tend to, as OBGYNs, kind of counsel them that too many C-sections lead to higher risk of complications. And actually, I mean, thinking about this topic with you, prepping for this, I was thinking, wow, having more vaginal births may contribute. I wanted to ask you if that's the case, if, how significant is it? Would it affect somebody's decision about how many children to have?
I think it would. I mean, there's pros and cons to everything. There is no easy way to like grow a human inside of you and have them leave your body. Like there's no easy way to do that. And there's risks if they come out of your abdomen, risks if they come out of your vagina. And obviously maybe it's not so obvious, I shouldn't say that. The risks of having multiple C-sections mean that you have more opportunities for scarring, adhesions, organ injury, and also placental disorders where the placenta can actually grow into the uterine scar. And that creates, some really catastrophic hemorrhages, and women can lose their uterus. Like those are not risks to be taken lightly. But it's true that nobody ever really talks about the risks of like many vaginal deliveries because that is thought to be like somehow riskless. And that's absolutely not true. I mean, I have so many friends, this is like anecdotal, where like maybe the first or the second baby, they didn't have XYZ issue. Then they have their third baby thinking it's going to be just like the first and the second one. And that's when their prolapse shows up. Or that is when they start leaking and it doesn't get better postpartum the way it did after the first or second baby. It's just so variable. And there's absolutely data to show that there's a linear like dose response, like more vaginal deliveries put you at higher risk of incontinence and prolapse. Like that is the facts.
Okay.
And, it doesn't mean you should change the way what you do. Like my mom had 8 babies. She wanted them all. She planned them all. Now she's a urogynecologist for a daughter, but
it's wonderful. Do you mind if I ask if they were all vaginal births? Did she really achieve all? Amazing.
They were. And I mean, especially as an OB-GYN, not to like put her whole obstetric history like out on the internet, but she is happy usually to talk about it. I always have asking questions about, my delivery, just like I now that I'm an OB-GYN, I have a lot more questions. And I was like, oh my God, like I was, of course, like a forceps delivery, and she pushed for like a really long time with me. And I was 42 weeks gestation, which like we would never let anyone go that far anymore. But in the 80s, they did. I was full term, 42-week induction, forceps. I'm like, Mom, it's like truly a miracle. Like that it all turned, I was a shoulder. They like pulled me into it's a miracle I'm even on this podcast today.
Oh my goodness.
But like
go ahead. Sorry.
No. I don't mean to keep interrupting you. I'm so sorry. I'm being podcasting, but
I do the same. I'm an interrupter. I have, and I seem to have booked all talkers, so we're all interrupters. It's okay.
I get just, really excited, as I think too many people. But I mean, her OB, who actually I met in medical school, he was my attending med school and he retired when I was a resident, like knew that she wanted a big family and was planning one and, really fought for her to have a vaginal delivery with me. And then she had 7 more vaginal deliveries and that was the right thing to do. Like, do I think she should have had 7 C-sections? No.
I know. I mean,
that would have been really bad.
That's amazing. You were the first, and they really, it sounds like they achieved that vaginal delivery with some challenges, difficulty. If you needed forceps and you were a shoulder, so you might have been, no offense. It sounds like,
I could have been
kind of
who knows,
at 42 weeks, kind of largish.
I always joke with her,
right?
I'm like, Mom, I would have gone to Harvard. Like, I know I became a doctor, but you don't know how much potential I could have had if I would have been a forceps C-section or a forceps shoulder dystocia. And she laughs and she's like, oh yeah, like, like many moms, everything's my fault.
I think it sounds like a very successable delivery. You're brilliant.
Yeah.
So
it sounds like it all turned out.
Well, your delivery story just just dropped a bunch of other risk factors besides a lot of births. Mentioned some other risk. If you could go over some other risk factors maybe in pregnancy and even at the time of delivery that increase your risk for pelvic floor disorders.
Yeah. So I mentioned forceps, and also like shout out to my mother. Like she actually is like built different, like doing very well.
Amazing.
Which is amazing. But forceps deliveries and vacuum deliveries, which are a little different. Vacuum is like the little suction cup for those of you who don't know. And forceps are like the metal sort of spoons that go around the baby's head to help deliver. Both of them have been shown to be significantly increased with the risk of incontinence and prolapse. And forceps are worse than a vacuum. So, we have that data. We know that. I believe the last time I looked at this data, it's like 9 times higher when you have forceps that you'll wind up with a pelvic floor disorder. And the mechanism for that is thought to be what's called a levator ani avulsion. So the levator ani muscles are the ones that they really do sort of attach to the pelvic bones, and they're kind of like right inside the vaginal opening. They're like the main sort of shelf of muscle. And if you can't, I'm showing this like on the screen, but I'm sorry, my light is not great. But these are levator ani muscles, and they kind of attach to the back of the pubic bone right here. And they can tear like off of the back of the pubic bone, especially with forceps. They can avulse, which means to tear off. So if those muscles tear off the back of the pubic bone, there's no real way to repair that. Like, it's really deep in the pelvis. There's no way at the time of delivery to like reattach those muscle bodies to the back of that bony pubic bone. And so then the pelvic floor kind of has this weakness where it just loses its attachment point. If you can imagine almost like a sail on a ship, like if it's torn off of one end, it's going to like flap in the wind. That's kind of like what's happening with your pelvic floor if it gets avulsed by some forceps. So it does really increase your risk of prolapse.
What about baby size?
Yes. Long story short, like yes, a bigger baby definitely.
And so that is not because more often you may need forceps and vacuum because of baby size, but that's an independent risk factor, right? Is that what you're saying?
I believe so, yes. When that data is, because women who don't have forceps or vacuums and have bigger babies absolutely have a higher risk of pelvic floor dysfunction, mostly because they have a higher risk of an oasis tear, which is an acronym for basically an anal sphincter tear. A big head definitely will. Basically, your pubic bone's up here, and so down here where the soft tissue is near the rectum, there's more stretch and give down there, so things are more likely to tear in this direction.
So I practice general gynecology now. It's been a number of years since I did OB, but at the time before I stopped doing OB, we really did not do episiotomies. And is that still the general recommendation to avoid that? And also,
yes, that's my understanding. I know the oasis literature pretty well. And yeah, definitely my day in residency, which wasn't that long ago, though it's getting farther away as the days go on. Definitely no episiotomies unless it was 100% like
needed. And I guess the impression I also had was that doing an episiotomy might make your tear worse, right?
Definitely the midline ones have been shown to make the tear into the rectum worse. And then people kind of started doing the medial-lateral ones, which are off to the side to avoid this sort of straight shot into the rectum. But those also, are associated with some decently bad tearing, more pain, definitely more dyspareunia, like pain with sex. So people are having effects of these.
I guess it sounds like the overall message is it's just a lot of, there's risk with vaginal birth, there's risk with C-section birth. You have to think about a lot of different factors and discuss this with your OBGYN about the best route of delivery and approach,
Agreed.
I guess I also want to talk about what are the kinds of treatments you do. Yes, maybe just a general overview.
I was going to say,
not
we need
details.
a whole other podcast for that.
Yes.
But absolutely, it obviously there's for incontinence and prolapse. We'll just stick with those two. There's conservative and then more invasive or surgical management, and there's several options between point A and point B. Numero uno for anyone and everyone is a referral to pelvic floor physical therapy. I cannot emphasize enough, how wonderful my pelvic floor and important my pelvic floor physical therapy colleagues are. They can treat to some extent, all of this, urge incontinence, stress incontinence, pelvic pain, pain with sex, and prolapse. Some prolapses, I mean, physical therapy is incredible, but it's also not like magic. There are some conditions that are severe enough that they don't respond as well to PT. So more severe prolapses and, more severe avulsions, but they definitely still have a role for PT. And then we kind of go from there. For stress incontinence, and prolapse, we have pessaries, which are basically a rubber dish. They have slightly different shapes. The ones for incontinence have like a knob on them. The ones for prolapse are basically like a big diaphragm or kind of like a diva cup. They're like a sort of flat plastic circle that's fitted to the width of your vagina. And those can help provide support to the urethra and the pelvic floor. And then from there, we get into things that are more procedural. So like on the stress incontinence side, we can do some injections into the urethra that kind of plump it up. I joke that those are like urethral fillers, like for your face, but for your bladder. We can do sling surgeries, which are like lightweight polypropylene meshes they're very safe. They've been on the market for a long time. There's really no litigation around those. They are inserted through the vagina. Those are for stress incontinence. They're very effective. The data for them is better in like an older population, like a more postmenopausal population. Younger women, there's not a lot of data on slings, but we still do them, of course. And then on the prolapse side, I mean, that's also a more complicated discussion. Like, do we want to do a surgery with or without a hysterectomy? Do we want to do a surgery with or without a mesh? It kind of depends on how bad the prolapse is, your age, your wishes, your goals, etc.
Well, you've given me several topics here that I'd love to invite you back to discuss, like PT, physical therapy, pelvic floor, and pessaries is a whole topic, and the surgeries. That's wonderful. What is insurance coverage like for most things?
Insurance covers most of the things that we do. There's some more, I guess, I don't know if experimental is the word, but when you get more into some like pelvic pain treatments, some other like uses of Botox for like pelvic floors that are in spasm, that's not always covered. That has things to do with like FDA approval, but for prolapse and incontinence, I will say that women with insurance have coverage for what we do.
Okay, good. That's great to hear because, I'm always reading about insurance denying a lot of things. And especially this, you would think that, I don't know. I do kind of feel like urinary incontinence is kind of something that people accept too much,
Absolutely. I mean, I don't see it as any different from having a knee injury. I mean, you have a bladder injury.
Right.
Your bladder's not working. Your bladder's job is to keep you dry, and it's not doing that. So we should pay to fix it.
So we are winding down. So I think maybe, do you have closing thoughts? Like, what's your message of the day?
Yeah. Thank you. Thank you, first of all, for having me. This was so lovely. I mean, I really think that my message is that I think as a society, we have really presented birth as an obligation, but actually it's an option. Not everyone, just because historically it's like you're a woman, you have babies. Like we've evolved past that. You can be thoughtful about like when you want to have kids, how many you want to have, maybe how you want to deliver them. I mean, you can only control so much, but there is a lot that you can control in terms of what's, what setting maybe you give birth in and what your risk factors are. And you can, demand more information and be more informed and really go into, the decision to be a parent very conscientiously and thoughtfully. And that doesn't make you unnatural as a mother. Like you're allowed to be, you're about to go through this like absolutely life and body altering thing that is really complicated and often goes right, but also can go really wrong. And, you're allowed to be hungry for more information before you proceed with a decision that big. And there's nothing wrong with you for wanting that information. I think that would be my take home message to anyone listening.
Yes, I have a little feminist angle for this podcast, and it's interesting because my closing thought was very similar. So I was going to basically just share that. I think the patriarchy would have us believe that, childbirth is easy and risk-free. But in the gynarchy, we know that that is not the case. It's not without risk, and we should go through pregnancy with open eyes, information, and only if we desire it, desire to have a pregnancy and a baby. And we should know about these risks. And it's so wonderful to know there's, doctors, wonderful doctors like you that can help women with the things that can happen. So my little motto for the show is down with the patriarchy and up with the gynarchy.
Love that. Well, thank you for having me. I'll come to the Gynarchy anytime.
Great. I love that. Jocelyn, can you please share with my audience where to find you if they want to follow your thoughts?
Yeah, I probably have the most thoughts on X or Twitter and Instagram, and my handle's the same on both. It's JJ Fitzgerald MD, but I also post some things on LinkedIn and a variety of other websites, channels, blogs. You'll find them.
Wonderful.
Most of them are cross-posted.
Great. She's a great follow. Do follow. Thank you so much for your time today.
Absolutely. And I'll talk to you soon. Thank you.
Bye.
Bye.
Did you enjoy this episode of the Gynarchy Podcast? Know someone else that might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Twitter, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.